Right. Today's lecture is going to be on urinary tract infection and vesicoureteral reflux in children. Why is urinary tract infection important in children and why we should be aware of this problem? This is important because 30 to 50% of the children with urinary tract infection have underlying problems affecting the kidney. Right. And the symptoms can be vague and they can be missed. So that is the main reason why it is important in children. And failure to treat these infections can sometimes lead to kidney scarring, hypertension, and if it is treated beyond certain time, then it may even lead to renal failure. So what is the incidence of urinary tract infection in childhood? Around 5% of girls and 2% of boys will have urinary tract infection during childhood. And before 3 months, boys are more susceptible. But after 3 months of age, the incidence of urinary tract infection in boys and girls are pretty much equal. Now, what is the pathogenesis? The urinary tract infection in children essentially can be dealt with like an interaction between the host and the organism. So the host is the child and the bacteria is the organism. So if the host becomes weak, the bacteria can attack, or if the bacteria becomes strong, the host cannot resist, like that. So E. coli is the commonest organism, accounting for around 80 to 90% of infections, followed by Pseudomonas, the most common non-enteric gram-negative pathogen. E. coli is common because it is a coliform; it is from the colon. Whereas this is a non-enteric pathogens, Pseudomonas can be an important cause, particularly in immunocompromised patients. Enterococcus is the most common gram-positive pathogen, followed by Streptococcus, Staphylococcus. Proteus can be a particular problem in boys, particularly uncircumcised boys. It lives in the foreskin, and Candida infections can sometimes be seen, particularly in preterm babies who are on multiple antibiotics, broad-spectrum antibiotics. Klebsiella again can be a cause of infection in immunocompromised patients and uncircumcised boys. What are the risk factors for urinary tract infection in children? They can be anatomic abnormalities like a vesicoureteral reflux. This is one of the important cause. It refers to the return of urine from the bladder to the kidneys. So that is the term for vesicoureteral reflux. It can be because of an obstruction to the passage of the urine in the form of hydronephrosis. It can be a posterior urethral valve or other causes like diverticulums, labial adhesions, etc. Female children are particularly more prone for urinary tract infections. That's partly because they are having more problems with the bowel bladder dysfunction. Then uncircumcised male children can have more incidence of urinary tract infection compared to circumcised children. Voiding dysfunction means the bladder does not hold and empty the urine normally. So these children try to contract the bladder sphincters while voiding, causing high pressure voiding. Constipation is often associated with this, and the constipation can cause the loading of the colon and thereby pushing the bladder neck and causing a mechanical obstruction as well. It can cause straining during passing motion, and it can also cause increased sphincter contractions, both external sphincter as well as anal sphincters. It can cause overgrowth of bacteria, which is again a reason for coliform infections, E. coli infections. Then instrumentation in the form of catheterizations, they are one of the known risks of urinary tract infection. Poor toilet training, pregnancy is an important cause, but that is that's not in children. What are the symptoms of urinary tract infections? In children, it is often non-specific, particularly in neonates and infants. They do not tell the typical symptom of urinary tract infection in the form of a dysuria. Dysuria means difficulty or discomfort while passing urine. There is also a term called LUTS, which refers to lower urinary tract symptoms in the form of dysuria, urgency, frequency, all those things. And there is a symptom called strangury, which means painful, incomplete voiding of that's called strangury. So those typical symptoms are often absent in neonates and infants. So they may present with the fever, lethargy, and the seizures, and these children may have non-localizing symptoms. They can have non-specific abdominal pain, vomiting. So we really don't know why they are unwell. Some of them may have fever. In neonates, there may not even be a fever. So if the child is unwell, one of the tests which has to be done is a urine routine and maybe a culture. In older children, whatever we have mentioned earlier in the form of a burning, micturition, urgency, frequency, flank pain, wetting, all those things can be classically elicited. A turbid and foul-smelling urine can be a symptom. The parents often come and report that the urine is cloudy. So it's like a buttermilk, they say. So that is a common symptom, even in neonates. So smelly urine and cloudy urine can be a symptom in a neonate, which is an indirect symptom told by the mother. Now, history taking is important in urinary tract infection. One has to go into the details of the features of bladder instability in the form of frequency, urgency. Bladder instability means the bladder keeps on contracting while there is voiding, while there is storage. So during storage, the bladder is supposed to be quiet. Whereas if it starts contracting, that's called detrusor overactivity or unstable contractions, and they can present in the form of a frequency, urgency, a small frequent voids. Then dysfunctional voiding refers to a contraction of the sphincter during emptying. So they also have associated holding maneuvers, straining, and Vincent's curtsy. Now, holding maneuvers can be in the form of crossing of the legs, squeezing of the perineum, pinching of the penis or foreskin. It can be in the form of crouching. Crouching means sitting in the on the floor with the crossed legs, with the heel pressed against the perineum. That's known as Vincent's curtsy sign. Then history of constipation is important. As I said, constipation can lead to bowel bladder dysfunction, also known as dysfunctional elimination syndrome. So that can be together present along with the voiding dysfunction. History of intake, fluid intake, the quality, quantity, then intake of bladder stimulants in the form of caffeine and blackcurrant that has to be obtained. Then bathing habits, how sometimes the children use bubble baths. They can irritate the perineum and then make them more prone to infections. Family history of urinary tract infections are important. How to diagnose a urinary tract infection? It is important to know how to collect the specimen, what are the rapid tests, what are the confirmatory tests. So those things are all important. So a significant bacteriuria means presence of a pure growth of more than 10 to the power 5 colony forming units of bacteria per ml. Now this is a simple definition, but this in itself is not complete because there are a lot of ifs and buts along with it. I will come to that in a minute. So lower counts may be important, particularly in specimens obtained by urinary catheter, and any growth is clinically important if obtained by suprapubic aspiration. So this is why this 10 to the power 5 cutoff is it should not be taken as an absolute value. So if you look at this table, if the urine is collected via suprapubic aspiration, then any growth, any number of bacilli or cocci, even a few thousand is important because there is a 99% possibility of infection if there is a growth on a suprapubic aspiration. If it is a transurethral catheter specimen, then you have a 10 to the power 5, 1 million organisms per colony count and that is has got a probability of 95% of having a urinary tract infection. Of course, lower counts also may have an infection likely. Then in a boy child, it's called a midstream specimen. The clean voided specimen means they discard, they clean the penis first, then discard the first few drops, then catch halfway through. That is called a midstream specimen. So there, more than 10 to the power 4 specimen also is significant. Infection is likely. Whereas in a girl child, more than 10 to the power 5 count is probably associated with a 95% suspicion, particularly if it is positive in 3 samples. Then less than 1 million count, it can be suspicious and one has to repeat it. Less than 10 to the power 4 means infection is unlikely. But if they are symptomatic, obviously, one has to repeat. So this is why what I told you is important. How to collect the specimen is important. Now coming to the rapid tests, what are the rapid tests? So this is called a urine dipstick. So you collect the urine specimen and put a dipstick into it. And then there are 2 important things which are important to suspect a urinary tract infection. So that is, one is a nitrite. So nitrite positive, then other one is the urease. So nitrite and urease positive. So these 2 tests are important. Then leukocyte positive. Leukocyte positive also is, that is another test. Nitrite and urease are the same. Your leukocyte positive, that is also can be tested on a dipstick. So that both of them together have got a strong correlation with the presence of an infection. Then the collected specimen can be looked under a microscope, and in the microscope, if you see bacteria, then that it is a strong suspicion of urinary tract infection. Then if you see a lot of leukocytes, more than 5, particularly in boys, and more than 10 in girls, so that is a significant pyuria. So that can be a suspicion of a urinary tract infection. So you still have to confirm them with the urine culture. Now, coming to the type of urinary tract infection, you can grade them into a simple UTI. A simple UTI means there is a low-grade fever, dysuria, frequency or urgency. So this low-grade UTI and dysuria, frequency, urgency means they probably have uncomplicated urinary tract infection. Whereas if there is a complicated urinary tract infection, they have fever more than 38 degree or 100 degree Fahrenheit, then vomiting, dehydration, renal angle tenderness. So these are all features of upper urinary tract infection, also known as pyelonephritis. Whereas a lower urinary tract infection, also known as cystitis, has got low-grade fever, dysuria, frequency, urgency. Now, recurrent UTI means a repeat infection with the second attack of infection with the same organism. So that is a recurrent UTI. A breakthrough urinary tract infection means a urine culture which is positive while the child is on antibiotic prophylaxis. So these are all important terms because when there is a complicated UTI or upper tract infection, then the evaluation becomes more important. When there is a recurrent UTI, the evaluation becomes important. When there is a breakthrough UTI, then some people take it as an evidence of indication for a surgical treatment. Whereas simple UTI means everything, the amount of evaluation is needed, amount of treatment is also less. So in infants more than 3 months and those with a simple urinary tract infection, oral antibiotics like amoxicillin, cotrimoxazole or cephalosporin are usually used. The usual duration of treatment is 10 to 14 days for complicated infection, whereas it is 7 to 10 days for a simple urinary tract infection. And again, the type of antibiotic, some people may elect to use an IV antibiotic if the child has got constitutional symptoms in the form of vomiting, high grade fever. So they may admit the patient, put the patient on IV antibiotics, and then watch the child. Maybe sometimes intravenous fluids also may be required. Whereas a simple cystitis probably needs an oral antibiotic for 7 days. Then after this course, starting prophylactic antibiotic until further evaluation in all children less than 2 years. Now, this is a slightly controversial statement. I'll come to that in a minute. So this is how the conventional evaluation for urinary tract infection is in the Indian setup. So after the first febrile UTI or pyelonephritis or high-grade UTI, all of them get an ultrasound, and if the ultrasound is abnormal, one goes for a micturating cystourethrogram or voiding cystourethrogram and a DMSA scan. The ultrasound is normal in infants, we still do an MCU and DMSA because the incidence of underlying vesicoureteric reflux or other abnormalities are still high. Whereas in 1 to 5 years, we do a DMSA scan first and followed by MCU, and then more than 5 years, we just follow up with ultrasounds. Now, this approach of doing DMSA first is known as top-down approach. So, if they have a normal DMSA scan, then it is unlikely to have a high-grade vesicoureteric reflux as a cause of urinary tract infection. Again, in the incidence of breakthrough infection is 60% in those with abnormal DMSA scan, whereas only 6% in those with normal DMSA scan. And the patients with abnormal DMSA scan have a lower likelihood of spontaneous resolution of VUR. So, having a DMSA scan helps in several things, like it helps to go for further evaluation. It also warns the physician that this is more serious problem because already some scarring has happened. So, DMSA scan stands for dimercaptosuccinic acid. So, this is a technetium scan where the technetium 99 labeled DMSA is injected intravenously and the child is made to lie prone position. And the images are taken. So these images tell the outline of the kidney. So it gives you the structure of the kidney and then maybe some scars also how the kidneys are affected. So this imaging tells you give an idea about the function and scarring and helping planning further. Now DMSA scan is relatively less invasive because only an IV a line is inserted and there's no catheter. Whereas in the if you look at the flow chart, the VCUG or MCU involves putting in a catheter, and that can be quite a traumatic experience in a child. So that is why the top-down approach, where the kidneys are looked at first, and if it is normal, then there is no need. Whereas if there is a scar or if the DMS is not available, you go for MCU or VCUG. So that is the top-down imaging approach. So these school perform the DMSA early within 30 days of urinary tract infection, and if it is normal, they reassure the parents that kidneys are normal and the child is unlikely to have a dilating VUR and skip the VCUG. Whereas if it is abnormal, they go for a VCUG, consider antibiotics versus surgery if the VUR is present, and then repeat the DMSA in 4 to 6 months to diagnose scars. So it spares a lot of children for the traumatic, invasive voiding cystourethrogram, and also the reduces the radiation. The DMSA scan has got less radiation than VCUG, it is less invasive, and it gives a lot of information about the kidneys. Now, role of other investigations. Ultrasound helps to detect dilatation of the pelvic cell system, ureteric dilatation, bladder wall thickening, ureterocele, post-void residual urine, and it is useful in the acute phase when obstruction is suspected. So ultrasound is a simple non-invasive test which can be performed in almost all children, but particularly in those with upper tract infection, it can be performed within the same admission. DMSA can be done after 3 months to detect scarring, whereas if it is an early DMSA, it is to look for pyelonephritis. So we prefer to do the DMSA scan little later, not immediately in 1 month time. We'll do it around some 3 months time to detect scar, and then if that shows scarring, then we'll go for MCU or VCUG. So that provides anatomical information about the urethra, about the ureters, about the outline of the bladder itself. It also gives a idea about the grading of the reflux. Now, nuclear cystogram is another imaging where the contrast is injected directly into the bladder via suprapubic puncture. It is less invasive because there is no catheter, less radiation, However, it demands an older cooperative child. It doesn't give a good anatomical information about the urethra or bladder. The grading is not 1 to 5, it is just a grade 1 to 3. So, grade 1 and 2 of VUR in VCUG form like 1 in nucleus histogram, 3 and 4 forms 2, and then 5th grade forms like 3. So, the grading is totally different. So, it can be confusing, and it is not ideal as a first investigation. Now, this is another slide which shows about the role of various imaging. Ultrasound, all boys within the first urinary tract infection, it gives an idea about the presence of an abscess, presence of 2 kidneys. Now, why this is important in children with renal agenesis or ectopic kidneys, there is a high chance of vesicoureteric reflux. Then it gives the size of the kidneys. If once one kidney is smaller, then there is a high chance of vesicoureteric reflux. Presence of hydronephrosis, again in the presence of hydronephrosis, there is an evidence of vesicoureteric reflux. Bladder wall thickening, that is an evidence of underlying either voiding dysfunction or posterior valve. Then it can give an idea of the postward residual urine, duplex collecting systems, ureterocele. So all those things can be diagnosed. Then vesicoureteric reflux, I mean VCUG is mainly done for vesicoureteric reflux and posterior valve. MAC3 scan is not often done. It is basically done only in the presence of hydronephrosis, like a PUG obstruction, whereas the DMSA scan is done to look for either pyelonephritis or to look for scarring. So, in children with the recurrent urinary tract infection, irrespective of the age of the child, an ultrasound, a DMSA, and MCU are required. Now, the NICE guidelines of 2007 said that consider UTI if it is unexplained fever of more than 38 degrees and symptoms and signs suggestive of urinary tract infection. And the recurrent UTI was defined as either 2 pyelonephritis or 1 pyelonephritis and 1 lower tract infection or 3 lower tract infection. Then atypical urinary tract infection was defined as presence of sepsis or abdominal or bladder mass or raised creatinine or no response to treatment after 48 hours or non-E. coli UTI. Now they defined the imaging as the DMSA scan in those less than 3 years for those with the recurrent or atypical urinary tract infection, usually after 3 months, and in older children only if it is a recurrent urinary tract infection. So the indications are like less than 6 months they do ultrasound abdomen, then more 6 months to 3 years they did further evaluation in the form of a DMSA scan. Then lower tract infection, they give a shorter duration of antibiotics, not exactly like how we do in India. So they give 3 days of oral antibiotics and for lower tract infections and 10 days for upper tract infection. Now antibiotic prophylaxis, the reason to give antibiotic prophylaxis is to prevent further infections, particularly in those children with vesicoureteric reflux or where the reflux is suspected. Now, there are some controversies on this. I will come to that later. Antibiotic prophylaxis, how to choose the antibiotic? It has to be effective, non-toxic, with very few side effects. They should not alter the natural flora, and they should not promote resistance. So, there is no ideal antibiotics, to be honest with you. So, it can be cephalexin of 10 milligram per kilogram night time for less than 3 months children. Then it can be cotrimoxazole 2 milligram per kilogram. Then nitrofurantoin 1 milligram per kilogram. So these are all some of the antibiotics commonly used. Now some of the measures to reduce recurrent urinary tract infections are to avoid tight undergarments, drink plenty of fluids, avoid bladder irritants in the form of coffee or blackcurrant, regular voiding, timed voiding, double voiding, perineal hygiene, controlling of the constipation, and circumcision in male children. Now, breakthrough UTI, the reason for breakthrough UTI, we have to look at carefully whether it is a resistant flora or whether the child is having a actually taking the medicine or spitting it out. Poor compliance can be a cause. Inadequate dosing, the child might have grown and put on weight and then maybe taking the still the old dose. Poor bladder emptying, host immunity, all those things have been used. Now coming to vesicoureteric reflux. Now 1 to 2% of general population may have vesicoureteric reflux. 15 to 20% of those with the antenatally diagnosed hydronephrosis have vesicoureteric reflux, and 30 to 50% of those who present with a urinary tract infection may have vesicoureteric reflux. So urinary tract infection and vesicoureteric reflux, it can be a dreaded combination. It has got a higher female preponderance. Now, vesicoureteric reflux in boys and girls are slightly different. In boys, it is more antenatally diagnosed, whereas in girls, it is more diagnosed after a urinary tract infection. In boys, it is usually high grade, and in girls, it's usually low grade. And in boys, anatomical factors are important, whereas in girls, dysfunctional factors are different. And the resolution is better in boys, the resolution is less in girls. Now, this particular diagram tells about the etiology of vesicoureteric reflux. Now, when I told anatomical and functional factors, anatomy means we have this sphincter, bladder, and this is the trigrone, and this is the ureteric orifice, which is seen here. Now, the ureters enter somewhere here into the bladder and then pass in the submucosal course and then open the ureter there. Whereas if the ureteric is entering a little bit higher, somewhere here, then there is a less intramural ureter and there's a shorter submucosal tunnel. So that forms the anatomical factor for reflux. Now, this particular theory is being questioned recently, whether actually that is the reason for reflux. But still, when we correct the surgery, this is what we look at and this is what we aim. We increase the tunnel of the ureter to prevent reflux. Now, functional factors, it can be an incoordination between the bladder and sphincter. So, detrusor sphincter dysenergia means while the bladder is contracting, the sphincter is supposed to relax. So, if the child contracts the sphincter during the voiding time, that can lead to rise in pressures. Or during the storage, if the bladder keeps on contracting, the detrusor keeps on contracting. So, that can be another functional factor for vesicoureteric reflux. So, in boys, anatomical factors are more common, and in girls, functional factors are more common. Now, reflux can be a primary reflux or a secondary reflux. A primary reflux means the reflux is because of one of the factors which I mentioned earlier, like an anatomical factor. There is no underlying obstructive uropathy or neurological problem. So the bladder shape itself is normal in primary reflux. It's usually the ureter itself. Whereas in a secondary reflux, there is an obstruction at the level of the posterior urethral valve, like what is seen here. The bladder is subnormal. It can be a neurogenic bladder in some children. Without a posterior urethral valve, they may have some other problem like a spina bifida or sacroiliagenesis that can cause the bladder pressures to rise, and that can be a cause of the secondary vesicoureteric reflux. So this is a neurogenic bladder causing a secondary vesicoureteric reflux. This is a bad looking bladder again. There is a diverticulum also here. So these are all the causes of the reflux in these children. So causes of secondary reflux can be posterior urethral valve, ureterocele, diverticulum, ectopic ureter, prune belly syndrome, bladder extrophy. Then it can be voiding dysfunction, neuropathic bladder, myelodysplasia, or sacroiliagenesis. So some of these causes of secondary reflux are so many here. In all these conditions, the bladder in ultrasound as well as VCG looks abnormal. Now coming to the two investigations which I told earlier between VCUG or MCU and a nuclear cystogram, an MCU has got more radiation, needs catheterization. So these are the advantages here. No radiation, less radiation can avoid a catheter. However, it gives excellent anatomical details. Exclude a posterior urethral valve. What you have seen earlier is the MCU. You can see the shape of the bladder, you can see the posterior valve, you can grade the reflux properly. So MCU is quite handy in that way. It can actually give you a better grading and then can give you a lot of anatomical details. So that is a nuclear cystogram where you don't get all these details. You can just say that this is a high grade reflux or no reflux. So that is the only information you can get in nuclear cystogram. But it can be useful for a follow-up when the patient is recovering from medical or surgical treatment. You can actually use a nuclear cystogram to get an idea. How to grade reflux? This is a grading on a VCUG or an MCU. Grade 1, undilated distal ureter. Grade 2, undilated distal entire ureter and maybe the calyceal system also. Grade 3, mild dilatation of the ureter and the calyceal system. Grade 4 is minimal tortuosity, dilatation of the calyces, but papillary impressions are present. Grade 5 is grossly dilated and tortuous ureter. Loss of papillary impressions, also known as clubbing of calyces. So these are all typical features of a grade 5 reflux. What is reflux nephropathy? In children with vesicoureteric reflux, DMSA scan reveals scarring in 25 to 40% of the children. So this can lead to hypertension in later life, and the hypertension can be seen in 10% with unilateral reflux and 20% in bilateral reflux. Now, there's a thing called a congenital reflux and global scarring, where at the time of birth itself, the kidneys are affected. So even without a UTI, the kidneys are globally scarred and then contracted, often have a high grade reflux associated. So this is a globally contracted kidney. Whereas in infective scarring is particularly seen at poles, upper pole and lower pole. This is because they have compound papilla and the intrarenal reflux is known in this condition. So that is a reason for scarring occurring at the poles. Now this is how the scarring looks like. This is a DMSA scan. So if you look at it, the shape of the kidney has to be a complete kidney shaped. Whereas here there is an area of punched out appearance. So there is a missing part of the renal cortex. So that is the scarring. Here again, the entire kidney looks a bit abnormal shape. So this is the same DMSA scan which is showing a loss of morphology. So here there is a upper and lower poles are scarred a little bit, unequal distribution called photopenic areas. Now this particular kidney has got a congenitally small contracted kidney, so that's a global scarring, and there is a compensated hypertrophy on the opposite side. So there probably is high grade reflux on this contracted kidney as well. So when this is the appearance of the scar on a macroscopic appearance, less than 1 year children, infants are particularly more prone for scarring. Frequent episodes of acute pyelonephritis means they are more prone for scarring. High grade vesicoureteric reflux, they are more prone for scarring. Then bacterial virulence, if the bacteria like fimbriated organisms like bacterial P factor, so they are having higher risk of scarring. Then if the host is weak, they have very immunogenic problems or genetically predisposing to the scarring. Certain genes are particularly associated with more scarring, and those are the higher risk factors for renal scarring. Now, what are the principles in management of vesicoureteric reflux? In the absence of urinary tract infection, isolated low pressure vesicoureteric reflux does not lead to scar formation. That was the old theory. So uncomplicated primary reflux resolves spontaneously. So in that combination, when you have a urinary tract infection and a VUR, you need both for the scarring to develop. So the UTI can be controlled by the antibiotic prophylaxis, and that can prevent the scarring. And a VUR can be contracted by the surgical treatment, so that can prevent scarring. So this was the old school of thought, and they all felt that either a medical treatment or surgical treatment are useful to prevent renal scarring. Whereas with the recent studies, what has been become aware is that the genetic predisposition to scarring is what is more important. They initially questioned the role of surgical treatment, saying that the surgical treatment with the reimplantation or any other intervention doesn't actually alter the risk of renal scarring. Then they later on question the role of medical treatment as well, like with antibiotic prophylaxis, that itself whether there is any role for preventing the scarring, because they are all genetically predisposed to scarring. So then they felt that there is no role for antibiotic prophylaxis. So these are all multiple studies on this randomized control trials on surgical versus medical treatment. So Birmingham reflux study looked at compared between medical and surgical treatment. International reflux study looked at compared between medical and surgical treatment. Then Smiley et al. Compared medical and surgical treatment. So they all felt initially that the medical treatment is as good as surgical, but even the medical treatment later on got questioned, and the role of antibiotic prophylaxis is becoming less and less important. Now, vesicoureteric reflux resolution. The lower the grade of reflux, the better the resolution rate is. In grade 1 reflux, the resolution rate is 80%. In grade 2, it is 60%. In grade 3, it is 40%. And as it becomes grade 4 and 5, the chance of resolution is less than 20%. Boys in the first year of life have got a better resolution even when they have a grade 4 and 5 reflux. So that is one of the favorable problems in neonatal reflux in boys they can resolve. However, after 1 year, the resolution in boys is very similar to the girls. Now, when somebody has a normal kidneys on DMSA, there is no scarring. Again, there is a better chance for resolution. And as I said, younger the age, the better the resolution chance. Then unilateral reflux, there's a better resolution chance than the bilateral reflux. No anatomical factors like diverticulum or duplex, they have better resolution. Then low pressure reflux, when they start refluxing during the filling phase itself, then that is a bad risk. So they have a less resolution chance. So this is known as the filling phase reflux, where we have already the reflux has already started while filling, so small volumes. So this is a very high reflux. This has got very little chance to resolve. So young male children, normal kidneys, low grade of reflux, no anatomical abnormality, no reflux in filling phase. So these are the ones who are favorable. Whereas somebody with a duplex system or a uretrocoel, so they are less likely to resolve spontaneously. These are all the poor risk candidates for this particular picture is a poor risk candidate for spontaneous resolution. Now there are calculators in the form of this is a children's hospital, Mayo Children's Hospital calculator. So you can actually select various parameters like age, how they present, etc. And once you enter boys with unilateral or bilateral reflux, urinary tract infection less than 1 year, then ureter anatomy they look for, time to resolution, and then that gives you a chance of resolution like 50% chance. So these are all available. Girls with the bilateral VUR, then less than 1 year, single system, 2 years, resolution 26. So you get the how the calculators can be useful. Now this particular image shows a lot of associated factors. Now this is an ultrasound showing a loaded rectum. So that is the rectal diameter. So if somebody has got a loaded rectum, then you have to treat them, because that itself can lead to bacterial translocation, obstructed voiding, dysfunctional voiding. If somebody has got a severe phimosis, again that also has to be treated. And this is an interrupted voiding. So this is an interrupted voiding is a feature of a Valsalva voiding. So they've got some bladder abnormality here. So this is the fimbrial factors. So multiple factors are there in treating a urinary tract infection. Until you treat them all in whole, look at all the factors present and then treat them. Treating the VUR alone is not enough. So medical management, antibiotic prophylaxis, urine surveillance, then treat the bladder dysfunction, regular follow-up, assess the compliance, maybe a DMSA scan is important. Then the question is when to stop the prophylaxis, the need for repeat MCU like RNCU. Now, what are the indications for surgery in a vesicoureteric reflux? In a primary vesicoureteric reflux, failure of conservative treatment in the form of a breakthrough infections, worsening of the renal function, or new scars. So these are the typical indications for surgical or endoscopic intervention. Breakthrough infection means the infection occur while somebody is on antibiotic prophylaxis. Then worsening renal function and development of new scars on a DMSA scan, they are well-known indications for treatment. Now, in a setup like India, where there is a poor follow-up or lack of compliance, somebody is coming from a faraway place like an Andaman Nicobar Islands, then that becomes a relative indication for intervention. Then high-grade reflux, grade 4 or 5 reflux, bilateral reflux, multiple scars. These are at the time of presentation. If all these factors are there, then I would be really worried about this child, and then maybe I will start, recommending surgical treatment for this patient. Then presence of anatomical factors like a duplex or paraureteric diverticulum. I already showed one image there. So that is a patient where the reflux is not going to disappear. How many years you wait? So you can actually tell them that this is a candidate for anatomical factors are there. So that probably is the case where waiting is not going to be useful. Now, obstructive refluxive megaureter, that is another indication where there is a high chance of recurrent urinary tract infection and upper tract damage. So that is an indication for surgery. Now, secondary VUR, ideally you have to treat the underlying cause. If there is a neurogenic bladder, treat the neurogenic bladder. If there is a posturethral valve, you treat the posturethral valve. So, a secondary VUR is a indication for treatment of the underlying cause rather than the V reflux itself. So, what is the treatment for reflux? So, as we discussed earlier, normal anti-reflux mechanism involves the ureter enters into the bladder here, and then there is a submucosal tunnel, and it opens at the trigone. So, you have to, there is a 5:1 tunnel length. So, the Paquin's rule is like to maintain this tunnel length or achieve this tunnel length. Usually, this tunnel length is inadequate in these children, and Cohen's reimplantation is a technique where it is an intravesical reimplantation where the ureter is brought across from one side to the other side and then fixed to the opposite side. So that is a typical Cohen's reimplantation where the ureter is brought across into a tunnel and then fixed to the opposite side. So that is one method of achieving extra length of the ureter. Then polytunnel-Ledbetter reimplantation is another form of reimplantation where there is no crossing of the ureter, but the ureter is actually made to enter a little bit higher place, and then the opening is made at the same place. Only the tunnel is increased, but on the same side without crossing. So this is an example of an intravesical infratrigonal reimplantation. This is an example of an intravesical supratrigonal reimplantation. Now this one is an extravesical reimplantation. Here are seeing the bladder from behind. So this is an extravesical dissection. So there is an incision around the bladder, the entry of the ureter at the vesicoureteric junction. Then the detrusor is incised there. Then ureter is buried inside the detrusor. So that is how after the incision, the detrusor is buried. Of course, one anchoring stitch is kept at the lowermost end. So this again, the principle is the same, to increase the length of the intramural portion. So there is a sandwich between the detrusor and the mucosa. So that is achieved by either intravesical technique where the ureter is brought further in, or intravesical technique where the ureteric entry point is taken higher up, or an extravesical technique where the ureteric entry point is taken higher up. The other options, as we said, circumcision is a useful option. Now, the sting procedure is a procedure where you put an endoscopic injection of a bulking agent in the form of deflux hyaluronic acid at the point of vesicoureteric junction. There is also another entity called Vantris. So that is also being used these days to inject. So this material actually causes a ball valve effect. So it makes that the ureteric orifice get compressed against the backing when the bladder fills. So when the bladder fills, this is there giving the support, and then the ureteric orifice gets narrowed, and when the bladder is started emptying, then actually the ureter starts contracting and then it works. So there is a 67% success rate with the first injection and 87% success with the second injection. So this particular treatment is useful in a grade 3 reflux or higher reflux. Grade 3 reflux particularly. In grade 4 and 5, it is not as effective. In grade 1, you don't need it. So ideally, this is suited in a grade 3 reflux. Now, I was telling about the systematic reviews on antibiotic prophylaxis. Now, there was evidence to support that the widespread use of antibiotics to prevent recurrent infection is weak, and antibiotic prophylaxis may be harmful due to side effects and emergence of resistance. So these evidences started coming in from 2006 onwards. There were multiple studies. So the antibiotic prophylaxis itself started being questioned. 14 needed prophylaxis to prevent 1 UTI. So N and T means numbers needed to treat. So whether you need that many children to prevent 1 urinary tract infection. So these were all being widely debated earlier. So the role of prophylactic antibiotics was getting less and less over the years. So the model was like original model was vesicouretal reflux and UTI both are needed for renal scarring, and prophylactic antibiotics prevented recurrent UTI. Surgery corrected the VUR. So that was the very simple and easy model. And later on, what happened was like a congenital scarring, all those things were having a role in renal scarring. So what happened was prompt diagnosis and treatment alone was needed. So what went away was that surgical treatment went away first. The medical treatment, prompt interventions and antibiotics. So later on, the antibiotic prophylaxis also went away. The American Urological Association guidelines on surgical treatment say that benefit of surgical treatment is there if the patient is older than 1 year old, if it is a high grade reflux, or if there is a renal scarring. And there is no consensus on grade 1 and grade 2 reflux. There is a thing called familial VUR in 32% of siblings and 66% of offsprings. There is a incidence of vesicouretal reflux in the family. So what is the role of sibling screening? Do only the younger siblings get screening, or if only if they are symptomatic? What about invasive versus non-invasive test? Ultrasound doesn't always pick up this scarring. So whether do they need to really undergo a DMSS scan or MCU? So these were all the questions present earlier. But nowadays, with the importance of antibiotic prophylaxis becoming less and less, the role of screening of siblings also is becoming less. Coming to bladder infection and urinary tract infection. So this particular diagram shows the chicken and the egg, like which came first, whether the egg came first or the chicken came first. This is a ubiquitous question which has been there. So like that, which started first, whether the UTI led to the dysfunction or the dysfunction led to the UTI, people never knew. But voiding dysfunction is definitely a known cause of urinary tract infection, and once it is treated, then the number of urinary tract infections becomes less, and then once the UTI is treated, probably the voiding dysfunction also can get better. Asymptomatic bacteriuria. Asymptomatic patients where there is more than 10 to the power 5 culture colony forming units per ml, no pyuria. So these are all E. coli of low virulence, may be seen in neurogenic bladders where pyuria may confuse again. Whether to treat them with antibiotics is a big question. So this is why it is important not to treat the culture on its face value. One has to look at the need to start antibiotics. If the child is asymptomatic, then one can actually repeat the urine sample and see what happens in the case of an asymptomatic bacteriuria. So to summarize, the treatment of vesicouretal reflux can lead to decreased number of pyelonephritis. It may not decrease the scar, but it definitely decreases the hospital admissions for recurrent febrile episodes and pyelonephritic illnesses. So that is an advantage of treating VUR. Now, grade is the strongest predictor of resolution. The older children with recurrent UTI, scars, and higher grade of reflux, these are the ideal candidates for surgical or endoscopic interventions. So, if somebody presents at the age of 5 with multiple scars and history of recurrent urinary tract infections, then I wouldn't start them on antibiotic prophylaxis or medical management. And they are probably ones where if the reflux is present on VCUG, that is not going to disappear. So that's probably something which needs to intervention. Now, one of the important cause of vesicoureteric reflux is posterior urethral valve. It often presents with the bilateral antenatal hydronephrosis, palpable bladder at birth, not passing urine after birth, dribbling only. They can present with the severe urinary tract infections, fever, or urosepsis, then failure to thrive, and they may even progress to renal failure. So the important thing is to suspect posterior valve in boys with bilateral hydroureteronephrosis. Ultrasound can be suggestive of this particular bilateral hydroureteronephrosis, and that is an MCU or avoiding cystourethrogram, which confirms the caliber change. The posterior urethra is dilated, anterior urethra is narrow, bladder is abnormal, and there is a bilateral grade 5 reflux, which is a secondary reflux. So in the past, they all were diverted, vesicostomy or ureterostomy, but the current treatment is endoscopic resection of the posterior valve. So ablation, endoscopic valve ablation or fulguration, and so basically the valve appears like a avascular leaflets, and they are cut at 3 points, 12, 5, and 7 o'clock. And these are the instruments used for endoscopic valve fulguration. Fetal diagnosis of posterior valve is possible these days. It's particularly possible in those where there is the features of severe bilateral hydronephrosis, oligohydramnios, and what is known as keyhole sign. So this is a keyhole sign. Keyhole sign means dilated posterior urethra and the bladder, thickened bladder looking like a keyhole. And oligohydramnios, an important part of oligohydramnios is posterior valve. This is because the amniotic fluid is essentially formed by the fetal urine, and once there is an obstruction to the passage of the urine, the amniotic volume becomes less. So when the amniotic volume becomes less, the lungs don't get perfused or filled with the amniotic fluid, so they can develop the pulmonary hypoplasia, respiratory distress, and they can also develop the squashed phases called Potter phases. So these are the things which you need to know: oligohydramnios, keyhole sign, then Potter phases, respiratory distress due to pulmonary hypoplasia. These are all features of posterior valve. In those with the poor prognostic group, termination can be offered. In those with the normal liquor and stable hydronephrosis, they can often be managed after birth. But there is an intermediate group where there is a severe oligohydramnios, but there is a normal karyotype and favorable renal parameters. Salvageable kidney function means fetal urine sampling shows sodium less than 100, chloride less than 90, osmolality less than 210, then beta 2 microglobulin less than 20. So when these factors are present, they can go for what is known as a vesico amniotic shunt, or also known as a Rodak shunt. So this shunt is placed between the amniotic fluid and the bladder, and they can get relieved of the oligohydramnios and the lung abnormalities. Nowadays, fetoscopic valve ablation can also be done. So that is about vesicoamniotic shunt. The complications are shunt blockage, migration, preterm labor, urinary ascites, all those things, then issues to survival. So that is about treatment of urinary tract infection, vesicoureteric reflux. If there is any question, I will answer. Otherwise, I will stop share with this particular topic, and then we will have a small break.